Hi, this video lecture addresses venous thrombolytic emboli and more specifically deep venous thrombosis or DVT and pulmonary embolism, otherwise known as PE. All right, so first of all, let's talk about what a venous thrombosis is. First, that's also known as thrombophlebitis, and it's a condition in which a thrombus or blood clot forms on the wall of a vein, and it's accompanied by inflammation of the vein wall and some degree of obstructed venous blood flow. So thrombus is a blood clot. And then a deep venous thrombosis or DVT occurs when the thrombus is located in a deep vein of the body. And the most common area for that to occur is in the lower legs, typically from like the knee down. Most common is the calf area of the leg. Okay, so 3 pathologic factors are associated with thrombophlebitis. And that includes, the first one is stasis of blood. And that's essentially where the blood is not flowing well through the area. So if we're talking about the legs, there would be kind of pooling in blood in the legs where it's not adequately circulating through there and back to the heart. And then the next factor is vessel damage. So, damage to a vein. And that could cause, happen from some kind of injury or maybe even a surgery. And then the third factor is increased blood coagulability. And that would be, if the patients might have like a clotting disorder or something like that, you could think of it as their blood's a little thicker. They're at a higher tendency to form clots at that point. So these 3 factors are known as Virchow's triad. Okay, so risk factors for a DVT. So really anything that would cause, one or more of those 3 factors. So if someone's not as mobile, like they're sick or they had a surgery and they're not up and walking around like they normally would be, that increases their risk of blood clot formation, particularly DVT. Surgeries, we talked about how not only are they probably not as mobile, but if they have, any type of vessel damage that occurred during that surgery, like, a vein or other vessel that was cut, then that increases the risk of blood clot formation. Cancer, we talked about trauma, again, that can cause some vessel damage. Pregnancy and delivery is a risk factor. And then hormone therapy, such as oral contraceptives and hormone replacement therapy increases the risk. And then there's some other, so atrial fibrillation, we've talked about that in a previous, or actually I'll talk about that in the other lecture associated with this module. So that increases the risk of blood clot formation. So you can listen to that lecture. MI, ischemic stroke. So these are all risk factors of blood clot formation. Okay, so your nursing assessment, you're going to get a health history. You want to assess for, symptoms of a DVT. Also, history of their current illness. Do they have any history of thrombus or clotting disorders? And then how does this affect their ability to participate in activities of daily living? And then physical exam, you're really just assessing the patient in whatever area is concerning. If it's their leg, you're going to assess their leg for these things listed here: redness, edema, tenderness, warmth, cord-like structures. Their body temperature could be elevated. So These are the clinical manifestations. I just mentioned many of them on the previous slide. So the leg that has the DVT in this picture is this one that I'm circling. So you can see the redness. You can see that it has some edema when compared with the other leg. So, remember here that the issue is venous. It's not arterial. So you will see this edema and kind of blood backing up congested due to this venous issue. They would still be expected to have perfusion to their foot and leg because, again, the blood clot's not in an artery, and arteries are what circulate blood to the peripheral tissue. So it's what's circulating blood to their foot, to their leg. So you would not expect an absence of pulse here. So diagnostics and collaboration. So obviously establishing the diagnosis is important. Preventing further clotting or extension of the existing clot. And then address the underlying causes that led to this clot formation so that those can be corrected or eliminated. Diagnostic tests. A D-dimer is a lab test that essentially will tell you if the patient has a thrombus anywhere in their body. So normal is 0 to 0.5. And so you would expect that the D-dimer would be elevated if they have a blood clot. So it'll tell you if there's a blood clot, but it won't tell you exactly where in their body a blood clot is located. So what it would look like if someone has suspicious symptoms for a blood clot, the provider might order a D-dimer. And then if it's elevated, then proceed with further diagnostic testing, like some imaging tests. So really, for a DVT, you're going to see most commonly an ultrasound, a duplex venous ultrasound of the affected extremity to see if a blood clot is there. These other 3 tests that are listed there are really kind of more specific exams that would be significantly more costly even. That would only be implemented if an ultrasound does not indeed detect a blood clot, but yet the provider thinks that there really is a blood clot there. Almost always an ultrasound is an effective imaging study for that, for a DVT. So prophylaxis would be, how are we going to prevent clients from getting DVTs? So there often might be on a low molecular weight heparin. That would be your Lovenox or enoxaparin. That's the same thing. So, sub-Q injections of that while they're in the hospital to prevent blood clot formation. Or maybe they'll be on some type of an oral anticoagulant. Most commonly, you'll see the Lovenox given. And then elevate the foot of the bed. Keeping knees slightly flexed will help. Early mobilization. So we don't want our patients just sitting in bed. We want them up and walking, doing leg exercises, range of motion exercises, using the intermittent pneumatic compression devices, or those are the SCDs, and then the elastic compression stockings like the TED hose. Those are all preventative measures for a DVT. So medications. So the patient is not going to be given a medication to break up the clot, bust the clot, because that's really not indicated here. The body will realistically just absorb this clot over a period of time. But these medications listed here, they all really have the same goal, and that would be to prevent the existing clot from getting any larger and to prevent the development of new clot formation. So whether it's heparin, the low molecular weight heparin, the Lovenox that we just talked about, or warfarin, these all have that same goal. Here's the thing though. The heparin, which is given typically as an IV drip, it will be effective immediately. Whereas the Coumadin or warfarin, which is an oral medication, like a pill, it takes 5 to 7 days to become fully effective. So what you might see happening is the patient to be placed on heparin and Coumadin at the same time, because by the time they're done really with their heparin therapy, then they will continue on their Coumadin because it will be effective at that point. So what else do you need to know about heparin? The dose is adjusted regularly per the protocol of whatever facility you're working. So every 6 hours would be kind of an expected time range. And the dose is adjusted as long as the physician is ordering it this way. The dose is adjusted according to the patient's lab test called an activated partial thromboplastin time, or APTT. So a normal APTT is 25 to 35 seconds, and that would need, so therapeutic APTT ranges for someone on a heparin drip would be 2 times that. So 50 to 70 seconds is what you'd want to see it at. So that's what that looks like. And so this heparin drip's a continuous IV infusion. And so then with the Lovenox, that is sub-Q injection, and really platelet count is monitored when you're giving Lovenox. And then the warfarin, like I said, that's a pill. That they do need a lab test called an INR, and the INR would be maintained at between 2 and 3, which would indicate that the warfarin is at therapeutic levels for that client. So they would have fairly frequent lab tests outpatient if they're on warfarin, and they would need to continue the warfarin for at least 3 months. And then all 3 of these medications greatly increase someone's risk for bleeding. So you'd want to talk to them about preventing injury, watching for bleeding, etc. Okay, so surgery. So most DVTs are not surgically removed. They just, give the patient an anticoagulant, and the DVT absorbs on its own. If the patient has an extensive DVT, like I'm talking, a patient I recently cared for had a DVT that was literally from their groin down to their foot. That DVT was surgically removed. So that is an option. Another surgical option would be something called an inferior vena cava filter, and then this one specifically is a Greenfield filter. I'm going to circle it. So it looks like an interesting little device, but that metal device is implanted in the patient in their inferior vena cava. The purpose of it is to catch blood clots to prevent them from moving to other areas of the body, like the lungs or the brain. So, if someone has one DVT, they're probably not going to implant this Greenfield filter. But if someone's continuing to have multiple, blood clot formation, then they would be a candidate for a vena cava filter. So, that the patient doesn't have further problems like a pulmonary embolism or a stroke from, the blood clots moving and lodging into those areas. So that's what a Greenfield filter is. So clinical therapy, you want to implement measures to reduce the patient's symptoms, reduce their inflammation. So you could consider warm, moist compresses, extremity rest, and some anti-inflammatory agents like NSAIDs or even steroids. Bed rest is really appropriate at first. You want to elevate their legs. Here's something important to know. You do not want to put the anti-embolism stockings or the SCDs on these patients. They are contraindicated for clients who have a known DVT because they could essentially break loose that blood clot, and then that blood clot could, lodge into the lungs or the brain or some other area. Those things are only used in the prevention of DVT development. So then the client's going to gradually return to activity, and at that point you would encourage walking, tell them to avoid prolonged sitting and standing, avoid crossing their legs, and avoid tight-fitting garments. So that's how what you would expect for a client with a DVT. All right. So nursing care, we want to manage their pain. So pharmacologic and non-pharmacologic pain management techniques, assess their pain frequently. You also want to measure their calf and thigh diameter, apply warm, moist heat, and then maintain bed rest as ordered. And then promoting peripheral perfusion. So assess their peripheral perfusion regularly, assess the patient regularly. Okay, promote client safety, monitor their lab values. So definitely if they're on a heparin drip, you're monitoring the APTT. Contact the provider for any values that are not within the desired range. And then, just monitor for signs of bleeding. And then encourage physical mobility once they're able to return to that. So range of motion exercises every 8 hours, frequent position changes, encourage increase in fluids and dietary fiber, assist with ambulation as needed, and then promote cardiopulmonary perfusion. You want to frequently assess their respiratory and cardiac status and check their vital signs regularly. So this is information related to education for a client who is discharging after having a DVT. So this is important information to know. All right, so now we're going to talk about pulmonary embolism. So an embolus is a particle or aggregate of blood, fat, or pathogens, or it can be a bubble of air. And it's really anything that's kind of freely floating in the bloodstream. So a thromboembolus is an embolus caused by a blood clot. So like a DVT that's located in a client's leg, let's say a part of that blood clot breaks loose, starts circulating in the client's body. At that point, it's an embolus. So thromboemboli develop in the venous system or the right side of the heart. Those are the most frequent areas that they develop, and thromboemboli are the most frequent cause of a pulmonary embolism, so the number one cause. Foreign bodies that have invaded the venous circulation, such as fat or bone marrow entering the circulation as a result of fracture or other trauma, is also, that would be considered like a foreign body or like a fat embolism. Tumors can also circulate in the bloodstream and be an embolism. And then amniotic fluid that is released into the circulation during childbirth would also be considered an embolus. And then an intravenous injection of air or other foreign substances could be considered an embolism and could be harmful to the client. So pulmonary embolism is the obstruction of blood flow in the part of the pulmonary vascular system by an embolus traveling from one area of the body to another. It is considered a medical emergency. 50% of deaths from PE occur within the first 2 hours following embolization. So prompt diagnosis and treatment is very important because it can help save lives and prevent complications associated with the pulmonary embolism. Okay, so thrombi that affect only the deep veins of the calf rarely embolize to the pulmonary circulation. Thrombi often spread proximally to the popliteal and iliofemoral veins, and there they may break loose to become an embolus. The embolus then enters the pulmonary arterial system. The effects of the embolism is there could either be occlusion of a large artery where a large area of lung tissue is affected, possible infarction, so that would create death of the lung tissue, or there could also be an obstruction of a small segment of the pulmonary circulation with no permanent lung injury. There can even be chronic or recurrent small emboli. So obstruction of pulmonary blood flow from an embolus affects both perfusion and ventilation. The neurohumeral reflexes triggered by obstruction cause vasoconstriction, increasing pulmonary vascular resistance, and can also lead to pulmonary hypertension and right ventricular heart failure. Hypotension and a drop in cardiac output may develop. Bronchoconstriction occurs in the affected area of the lung. Dead space, which is an area of the lung that is ventilated but not perfused, increases. Alveolar surfactant decreases, and that increases the risk for atelectasis, which atelectasis is like collapse of those alveoli, those little air sacs that their job is for tissue perfusion. Okay, so anyway, if those alveoli are collapsed, then that area of the lung is not adequately ventilating and oxygenating the blood. So if infarction does not occur, the fibrinolytic system dissolves the clot and pulmonary function returns to normal. If infarction does occur, the infarcted tissue becomes scarred and fibrotic. Thrombus arising from the deep veins of the legs is the leading cause of a pulmonary embolism. So a DVT is the leading cause of a pulmonary embolism. A less common source, as we previously discussed, are some of those other sources, but fat tissue that enters the circulatory system can become an embolus that could result from a surgery or trauma. And they're really the most common non-thrombotic cause of a pulmonary embolism. So non-thrombotic, so non-blood clot cause. A fat embolism usually occurs after fracture of a long bone, so typically the femur, releases bone marrow fat into the circulation. Okay, so this image is really just a picture of how a blood clot, like a DVT, would move from the legs to the lung tissue. Okay, let's go on to the next slide. So this is what you'd expect to see when a patient has a pulmonary embolism. So this person has a lot of emboli, if you will. So here's one. This one's still in the circulation. It hasn't lodged anywhere yet. But like here's one, here's one, here's one. It looks like this one right here that I just circled is affecting a pretty large area of lung tissue, because if you look, like this whole area right here, see, it looks like it's purple and kind of dying, if you will. So here's one over here but it just looks like it's affecting this smaller area of lung tissue. So really it depends upon where the blood clot lodges or the embolism lodges as to what's going to be affected. So obviously the person who has this situation where this whole big area of lung tissue is affected is going to be one that's more likely to have some major complications and to possibly have a sudden death from it. Whereas this one with less damage is going to be less likely to have some of those major issues. Okay, so your health history. So you want to assess for these symptoms listed here, the history of their current illness, precipitating factors, and then any risk factors of developing a blood clot that we've previously talked about, as well as current medications. And you really want to know, do they have a history of this blood clot formation in the past, or a history of a recent surgery, or a recent, period of immobility that would increase the risk of this. Physical exam, you want to assess their level of consciousness, as well as their vital signs, pulses, so central and peripheral pulses, their respiratory status, skin color and temperature, as well as moisture. Heart and lung assessment is appropriate. Look for neck vein distension, as well as peripheral edema. So, because if they have a DVT present as well, they would have possibly peripheral edema. And then you want to analyze their cardiac rhythm. Okay, so risk factors of a PE are really very similar, as you can see, to those of a DVT. So I'm not going to read these to you because they're nearly identical. And then the clinical manifestations listed here, clients often become very anxious and have this sudden feeling of impending doom whenever they develop a blood clot. And then obviously some respiratory symptoms and possible cardiac symptoms. Okay, so collaboration. So ultimately we want to prevent these from occurring because we talked about the increased risk for sudden death. And then otherwise the treatment, you want to try to provide supportive treatment. So oxygen as needed, analgesics to help with their pain and fever if they have fever. Pulmonary pressures, if that's appropriate, that would be something really done in the ICU if that's where they're at. Cardiac output, cardiac rhythm, you're definitely wanting to monitor their cardiac rhythm. And then again, the diagnostics, we talked about plasma D-dimer. So really, if that D-dimer is elevated and the patient is having respiratory symptoms and chest pain, a chest CT would be the expected test to see if they've got a PE. Really, it wouldn't show up on a chest x-ray, but perhaps a chest x-ray might find other potential causes of, their symptoms. But chest CT is kind of the gold standard. And some of these other tests, like lung scans, pulmonary angiography, those would really be more specialized tests that would be implemented if the client, if a CT doesn't show them what they need to know, or if the client is allergic to IV contrast, then they're probably going to have like a lung scan instead. And an ECG would be really to monitor, to see what their heart rhythm is, if they've got any cardiac issues with this. Arterial blood gases, that's lab work that assesses for oxygenation, and those would be appropriate to assess, as well as coagulation studies and end-tidal carbon dioxide. If the patient's on oxygen, that could be monitored with special oxygen tubing. All right, so really the heparin and warfarin again would be appropriate here, and it would be a same situation as a DVT. Heparin drip and then warfarin would be expected to be started at that same time because of, taking 5 to 7 days to be effective. And then there's fibrinolytic therapy, and that would be that clot busting medication that essentially would break up all clots in the client's body. So this is a very dangerous high-risk group of medications that greatly increases one's risk of bleeding, particularly bleeding in their brain. And so there are lots of exclusion factors involved here, like recent surgeries, history of previous stroke, things like that the client might not be a candidate for this therapy. Surgery, again, they might need an insertion of an inferior vena cava filter. We talked about that earlier. If they've got like a history of having multiple blood clot formations. And then this is appropriate client teaching related to pulmonary embolism. So our nursing care, you want to compensate for impaired gas exchange. So assess their respiratory status, place them in a position to help facilitate breathing. So Fowler or high Fowler position, monitor their labs such as arterial blood gases, monitor their vital signs, maintain bed rest, preserve cardiac output. So auscultate their heart sounds, assess their skin color and temperature, monitor their cardiac rhythm, administer medications, monitor pressures, vein distension, edema, maintain IV access sites, instruct on symptom reporting, and then promote safety. So really assess for signs of bleeding because they're going to be on an anticoagulant or possibly even receive fibrinolytic therapy. So fibrinolytic therapy would really be just for patients who have a major thrombus that's going to cause severe damage and possible lung tissue death if that blood clot is not, removed immediately or broken up immediately. Otherwise, a PE is typically going to be expected to resolve on its own. And the body will absorb it, kind of like a DVT. Avoid invasive procedures, obviously, if someone has an anticoagulant or fibrolytic therapy. And then relieve anxiety. So assess your client regularly, stay with them as able, explain things like procedures and treatments, reduce environmental stimuli, encourage family support, and administer analgesics. And that is the end of this presentation. Thank you for watching.